next topic I'd like to cover is proton beam radiation to the chest, and usually in the setting of locally advanced lung cancer, as opposed to conventional or photon radiation therapy that's broadly available. And there were a couple of studies presented back to back that came to somewhat different conclusions, neither really definitive, but we're in a world where there's a lot of controversy, there's a lot of advertisement and frankly innuendo that proton beam radiation is a superior approach. It's certainly newer, it's more expensive, it's got limited availability, and there's certainly a mechanism of action to suggest that it could be better, but we don't have a lot of data yet. And there was a prospective trial that was not large that directly compared proton beam to conventional radiation that showed no significant differences. And there was a retrospective study that actually folks from your own institution led that looked at thousands of patients. Only a small fraction had received proton beam radiation and did see better results, but with a question of selection bias. So maybe I'll come to you after, because you certainly, I know, will have thoughts about this, but Everett, can you give us some thoughts about what you see as the state of the field right now, and if there's anything that is likely to change that soon?
This is for stage 3 disease?
Yeah, let's say stage 3 primarily.
Yeah, I think it's an unchanged standard of concurrent chemoradiation with carbotaxol as one option and cisplatin etoposide as an alternative. And based on a trial that is maybe not conclusive in the end, I would add cisplatin and pemetrexed.
Mm-hmm.
It was a failed trial in a way because superiority wasn't shown, and it wasn't large enough to show non-inferiority, but
Mm-hmm.
the curves overlap so
Mm-hmm.
that a clinician would have to say, this is pretty much the same.
But for the radiation side?
On the radiation side, we know that just escalating the dose is not the answer.
Mm-hmm.
So 60 gray is the standard now,
Mm-hmm.
and going higher is not. Although many people would argue that that had to do with toxicity, and that more precise delivery of radiation, maybe through protons, could lead to better local control. So then that becomes the hypothesis, right? And that, of course, is not what these current data are going after, because they're just trying to look at, I think, toxicity or maybe better outcome using the same dose. They're not addressing the feasibility of protons as a better tool to escalate dose, which might be the other question. So, as I look at this, these are very, very expensive machineries. As you say, they're being used to promote institutions. I think much more than they're promoting science. And, definitive data are not available. They were not available before ASCO, and what I'm hearing, they're still not available after ASCO, despite 2 presentations.
What are your thoughts, Janet?
Well, it's certainly appealing as a patient to think that when I receive radiation, that the beam will stop just shortly after my tumor and not go all the way through. I am one of many patients I know that have side effects from, or either late side effects from radiation because certain nerves got hit or certain muscles have become fibrotic or not working right. So being able to avoid that would be very appealing. It would be interesting to know how the toxicity was on this trial.
What were your thoughts on this?
So, proton therapy is very much an evolving technique. I think in certain situations, such as in pediatric patients, there are some very clear benefits because of reduction in long-term toxicities. In lung cancer, we're still learning, and this particular trial, even within the duration in which the trial was done in MD Anderson, they had a big learning curve. They showed that patients who were treated before the year 2011 didn't do as well as patients treated after the year 2011. Mm-hmm. So it's still a learning process, and for us to say we know how to treat patients and protons are better are not bound by the evidence. But what they compared with was IMRT, which is also a very focused form of radiation. It was not like they were giving the conventional radiation where patients were getting big doses to the heart, which is always a concern. Mm-hmm. So this is comparing apples to a large part, but the technology is emerging, and there is a randomized trial that's being done, and that trial is designed to answer this question definitively. So at this point, I agree with Everett Everett's concerned that we don't want this to be just driven because institutions have the facility and they want to promote this. We want science to lead to practice. What we saw in our analysis that we reported at this meeting was how is proton used across the country. We looked at a national cancer database, and there were only 350 patients over the time period we looked at. And what we saw was patients with higher educational status, higher income status were more likely to be represented.
Well,
in
given
these,
that it's not covered by insurance.
That was
Well,
another issue.
Actually, more patients got proton with government insurance than with private insurance because they may have faced pushback from private payers. So there was a lot of what we feel are selection bias in who gets proton therapy, and that may select out for patients who have better outcomes. So will that be something that you can broadly apply to any patient with stage 3 lung cancer? The answer is no. We need to study it carefully, and I would encourage patients who are interested in these kind of approach to hopefully be able to participate in these trials.
This reminds me of a study we had, a paper we had about 10 years ago that looked simply with head and neck cancer at driving distance. And the patients who had a longer commute to our facility did better than those who had a short commute. And I think it is exactly that phenomenon of people selecting an institution very carefully where they can go to, and being motivated and maybe less handicapped, and having better social support.
So much as I would like to say that the whole theory says that absolutely proton is better, there are some people that said that higher radiation, more grays of radiation had to be better, right, because it would fry more, and the patients did not do as well. So I realized the need to have a trial to prove it out.
I mean,
That's a very good
we have a
point.
long history of guessing wrong, and it's not, we're not infallible. Years ago, 10, 12 years ago, everyone thought that gefitinib Iressa, an EGFR inhibitor that helped quite a few patients, it was imagined that that would be at least as good as doing nothing, and then potentially much better. And in fact, when the randomized trial was done, giving this or placebo after chemo and radiation, had we not done the placebo-controlled trial, we wouldn't know that the placebo arm did significantly better and we were harming patients. Everett mentioned that the trial of standard dose versus escalated dose chest radiation backfired and showed a higher survival in the lower dose. That was a trial that many thought was unethical to enroll to because it was enrolling in what many thought was just had to be an inferior approach of giving less. But sometimes we don't know as much as we thought we did. So that's the value of the trials. I guess in this case, it's valuable that we didn't show outright futility, and it didn't close the case that Proton-Beam is incontrovertibly better, and the trial ideally will be done to give us a clearer sense of it than we got from this.
Mm-hmm.